Hey, deserving listeners, it's just me today. I thought I would respond to some patron emails. This first email is from an anonymous patron. She writes, I've been studying in my drug and alcohol program, and I have become hyper aware of my psychology. And I seem to want to diagnose myself with all kinds of things in the DSM. I actually have a history of trauma, but I've never been treated for it. I find myself doing, I find myself I found myself diagnosing myself with a bunch of different disorders, and now I'm paranoid that there's something really wrong with me. What do you think about that? I need help. Good question. Yeah, this is a common thing for first off, let's introduce the podcast. This is the Psychology in Seattle podcast. I'm your host, Dr. Kirk Honda. I'm a therapist and a professor. Yeah, anonymous patron, good questions. These are common problems for grad students in the helping professions when they take a psychopathology course. I remember my classmates doing this when I was in graduate school in the mid-90s. I don't remember doing it myself, though, although I do remember that I did, for the first time, realize what I had been suffering from, which was panic disorder. Prior to taking my psychopathology class in, I believe, 1994-ish, maybe early 1995, I had been experiencing a lot of very perplexing symptoms that I thought had to do with, I don't know, just some sort of general craziness and maybe a heart condition. And upon learning about panic disorder and anxiety disorders in general, I realized, I was suffering from this very low-grade mental condition called panic disorder, and it made me feel so much better because what I thought I was suffering from was something that would kill me, or I was going to go insane or something. And so I do remember that. I do remember when we got to the anxiety chapter and we studied panic, I was like, oh, wow, that makes me feel a lot better. So I do remember that. So to answer your question, you're in a drug and alcohol program, you're taking classes on the DSM, and you're like, oh my God, I have a whole bunch of diagnoses. Well, first off, we need to discuss what the DSM means exactly. If you're not aware, the DSM is our diagnostic Bible that all mental professionals use. And it just contains labels. They're not actual things. I've talked about this on the podcast before. In biology, in the medical field, when you are diagnosed with a tumor in your colon, they can find the tumor. They can go to the tumor in your body and take a bio sample and do some tests under a microscope and actually determine, yes, you have cancer in your colon. When you are diagnosed with a DSM, quote unquote, diagnosis, there is no such physical evidence. It's all based on a clinician interviewing or testing. And these tests, again, we use words like tests, but they're more like an investigator trying to figure something out. They're not, when you do a lab test for your cholesterol, these are a different kind of test. There's no opinion in there. You send it, physicians don't argue about how much cholesterol was in the blood sample because the method of measuring that has been proven to or demonstrated to be reliable. And so physicians say, okay, well, that's what it says. Then that's what we're going to go with. Whereas in my field, you get 10 clinicians in a room and they look at the exact same patient. You're going to see different diagnostic opinions. And therefore, the tests, quote unquote, tests that we conduct to determine if someone has a diagnosis, they're not hard science. It's a matter of trying to triangulate certain things, and a lot of opinion comes into play. Now, some people fit very easily within a diagnostic category. For example, when I had my panic attacks, I was classic. There was really nothing ambiguous about it. It was a classic panic disorder. Well, actually, one could say I had PTSD actually, and I was experiencing panic in the midst of PTSD, I suppose. But anyway, there are some things that most clinicians will say, yeah, that's what that looks like. But again, it's not a hard science. It's based on what we have constructed. And over time, we have constructed different diagnostic labels and categories and systems. And so the same person being diagnosed by a mental health person in the 60s might have found something different than they would today because they had different categories back then. So it's not a hard science, like I said. They're just labels, they're not actual things. The reason why we have the DSM, so people say, well, why have the DSM? It's all a bunch of bullshit. And I'm just like, no, you don't understand how the DSM works. If we didn't have the DSM, we would just develop some other way of communicating with each other. And that's all the DSM is that it helps clinicians to communicate with one another and researchers to communicate with one another. When instead of talking about every patient in this long form manner, we can categorize their experiences into small phrases, like this person's suffering from major depressive disorder. And instead of saying, let me tell you the history of this person's life and all of the symptoms, so to speak, that they are complaining of, that's all that these labels are. They just provide a quick way of being able to communicate. Plus, it provides a quick way of categorizing different kind of presenting problems that people come in. And it also helps us to devise treatment plans and to test those treatment plans and research. If we didn't have these labels like major depression, we wouldn't have any way of knowing what sort of treatments work for what sort of presenting problems that people come in with. And so it's just a labeling system of a rough categorization of symptoms that people will present with, and it's a way for us to communicate with each other, to do research, and to develop treatment plans. But that's all that it is. And frequently with my supervisees and students, when I ask them to assess a patient that they're working with, I ask them to absolutely demonstrate that they can diagnose and they can do that systematically and do it well. It's actually a learned skill. It takes years to develop. But I also ask them to, that's just part of the picture, that the diagnosis, although something that, funding and insurance companies focus on solely, us as clinicians, that would be really ridiculous because people are much more complex than that. And people exist in a system, in a culture, and in circumstance. And therefore, just understanding their quote unquote diagnosis is a little silly. The reason why I'm putting diagnosis in quotes in this discussion is that the word diagnosis to most people, and even to many mental health people, implies some kind of hard science, right? When I fall off the roof and I break my arm, there's a diagnosis of a broken arm, and you can do that you can measure it with an X-ray, and you have a diagnosis broken arm. When you have leukemia, there's a diagnosis of leukemia. Well, when you're diagnosed with any kind of label in the DSM, that is a different experience and a different philosophical undertaking. And so it just is important to, that's why I'm quoting diagnosis. Okay. The other thing, anonymous patron, that you should know is that you're in a drug and alcohol program, which I'm guessing means that you're not learning how to properly diagnose people. You're probably learning about the DSM because in your drug and alcohol program, you need to know a little bit about it, because in your work, you're going to be diagnosing people with substance use disorders. And so you need to know those. And plus, you probably need to know generally the other categories of disorders that are that we have decided to label and discuss. but I'm guessing that as a drug and alcohol person, you're not being trained and won't be qualified to actually diagnose people outside of those substance use disorders. So take that into consideration. You're not, and my guess is you're not really getting the full education of a diagnostician. And so, and even some people who have that full training, they have a difficult time diagnosing people themselves because it's a very complicated thing, particularly the more complicated disorders. Also, another thing to know is that just reading the symptoms in the DSM and reading the short little introduction, it will not help you understand how to diagnose people. Again, particularly the more complicated ones. Yet, if you read the diagnostic criteria for, say, borderline personality disorder, that is a far cry from being able to diagnose someone with borderline. I know clinicians who have been working in the field for 10 or 20 years and, for the most part, know how to diagnose people. They know what borderline personality disorder is. But in my experience, many people do not know how to diagnose that. And it takes a specialist, takes someone who really understands that disorder, really understands the history of the label, the way people present, the course that it presents over time, how to understand differential diagnoses. And so just, I'm imagining you're in a drug and alcohol program, you took a class on the DSM, for a few months, you're reading the DSM, and the DSM is 700, 800 pages long. So, it's a lot to cover in a class. And so I'm just guessing that the amount of education you're getting is not going to make it so that you can diagnose properly. And you're not claiming that. But my point is that just because it seems like some of these labels apply to you does not mean they actually apply to you. That's a very important thing to understand. Also, you're saying, well, I was traumatized, so it's possible that I actually do qualify for a number of these labels. And what I'll say to that is, yeah, it's possible. When people are traumatized, a wide variety of disorders in the DSM can develop. But the issue here is that when someone does a full assessment of someone like you that may or may not actually qualify for a bunch of labels, what they'll do is they'll pick a small set, maybe even just one salient label. For example, if you suffer from complex PTSD, which actually isn't in the DSM, but let's just say PTSD, then you will also qualify for depression. In all likelihood, you'll qualify for anxiety disorders, panic, social anxiety, OCD, maybe, generalized anxiety. You will maybe suffer from attachment disorders that are in the DSM. You might suffer from dissociative disorders, but the salient label might be just PTSD with some dissociative features or something. So just because someone qualifies for a bunch of labels doesn't mean that a diagnostician would actually apply all the labels. I mean, I'm just thinking about what that would look like in my practice if I just read the DSM and with every patient of mine and just thought, okay, well, what are all the labels that would possibly be legitimate labels for this client? I mean, I'm guessing the average person would qualify for like 20 or 30 different labels in the DSM. So it's and again, that should give you some kind of idea of how squishy and how soft of a science diagnosing is that when you are suffering, I'm guessing in the medical profession, from a broken arm, you don't qualify for 30 different diagnoses. I mean, maybe you do. Maybe there's a whole bunch of different ones. Anyway, the point is that the number of labels that you qualify for isn't some kind of strange thing if you qualify for a bunch. Also, another thing is that at any given time, a third of Americans, and really even potentially of people outside the United States, will qualify for a label. at any given time. And half of Americans will qualify for a label in the DSM at some point in their life. So the fact that you qualify, or you think you qualify for some of these labels is means you're really just a common, normal person, particularly if you've been traumatized. The other thing here that I want to say is that within your email, you're basically saying, "Oh my God, I might qualify for a bunch of labels in the DSM, and there's something wrong with me." You're worried there's something wrong with you, and that's something that I hear a lot from people. It's like, "Oh my God, I have all these labels," and people make jokes. It's like, "Oh boy, I'm crazy. I got all sorts of labels in the DSM." And this is really wrong-headed in my opinion. Number one, like I said, the DSM is just a way for us to provide helpful labels. There's no judgment about your quality as a human being if you qualify for one or more of these labels. It shouldn't be associated with that. We do in our culture because we're stupid humans and we don't understand how to think logically, and so we equate diagnoses in the DSM as some sort of measure of your worth on this planet or something. But the way to think about this is, if you've been traumatized, as you say, and you have what I would consider to be extremely normal effects from that trauma, that's normal. There's nothing wrong with you. If someone crashed into you on the highway and you crashed into your car, and as a result of the crash, you broke your arm and you were in pain later, and so you go to the physician, and the physician diagnoses you with, a broken arm or some kind of, they messed up your elbow or something. You wouldn't think there was something wrong with you, would you? You would just say, "Oh man, when that asshole ran into me on the highway, he broke my arm. That, God damn it." Well, that's the same when it comes to trauma and labels in the DSM. If someone traumatized you, or you went through some kind of situational trauma, and as a result you have a normal reaction to that and that normal reaction consists of experiences and quote unquote symptoms that allow for a qualified clinician to diagnose you or to label you with something in the DSM, then that means you're normal. When people go through trauma, many of those people, if not a majority, have emerged from that experience with some kind of label in the DSM. Plus, even if you were born, quote unquote, born with a disposition for depression or some other kind of issue in the DSM, and so let's say you weren't traumatized and you're raised really well, and yet you still develop some kind of mental condition like depression, there's no shame in that. So there's no path to a mental condition, however many one qualifies for, that it justifies feeling bad about yourself, or there's something wrong with you, or there's something to be alarmed by. It's sort of like, to me, it's like if you were diagnosed with, say, HIV or cancer, there's a reason, I think, to be terrified of that. Oh my God, prior to this moment, I didn't know I had cancer, and now I do. Prior to this moment, I didn't know I had HIV, and now I do. And all the implications, and what does this all mean? It's never a good thing. And so, or I don't know, it's rarely a good thing. So I understand that kind of anxiety, but the anxiety for someone who is, say, like you, who's been traumatized and who probably on a daily basis knows how that trauma is affecting you. Maybe you're a little anxious, maybe you get sad about it, or you try not to think about it, or whatever. I have no idea. You didn't tell me anything about that, but you're experiencing those quote unquote symptoms. And just because there's a label in the DSM for that doesn't mean that you've suddenly acquired some problem, at least from my point of view. I'm sure other people could have other ways of looking at it, but to me, we just have to define shame and stigma. And really in particular, we have to define what justifiable shame is. And let me talk about that for a second. Justifiable shame is knowingly doing something harmful for no good reason. This is my definition. Like stealing from your friend, just because they have something that you want. They have a diamond ring that you like, and so you just steal it. Well, you should be ashamed of that if that's what you're going to do. That's why we have the emotion shame, of social and internal shame. It's to regulate behaviors like this where we do something that is not cool. That's why we have shame. So that's justifiable shame. The other thing is stigma. We have to talk about, well, what is stigma? Because sometimes we equate stigma with shame. I do it too. All humans do it. Stigma is something that has been socially constructed by society and culture, and sometimes it's right-headed and sometimes it's wrong-headed. We tend to have stigma about stigma, I guess. We tend to think, well, stigma is bad. Well, no, stigma can be very good sometimes. There are stigmas about driving crazy on the highway, for example, or driving drunk on the highway and running into people. If you got drunk and ran into someone and broke their arm, there would be stigma about that, and that's not something you're gonna brag about at work on Monday, the next work week. So that's right-headed stigma. You should feel bad about that. You should feel some shame about the fact that you drove drunk on the highway and hurt somebody. Or another stigma in our society is, people who have sex with children. There's stigma about that. Now, it can be taken too far, and it can have all these bad effects, but that's right-headed stigma. But some stigmas are not right-headed, and I would venture to say most stigmas are not right-headed. For example, qualifying for something in the DSM, being labeled with 15 different disorders from the DSM should carry no stigma with it. That's wrong-headed stigma. We, as a society, for whatever reason, a long time ago, probably as a result of capitalism or, I don't know, just something that we don't understand, we decided that people who are quote-unquote crazy are sort of subhuman, or they're scary to us, or they don't deserve our respect, or we're worried they're going to kill us or eat our children, or I don't know what. There's just this weird stigma. Again, half of Americans have a label, qualify for a label at some point in their life. So it's extremely mundane to have to qualify for a disorder in the DSM. So to have stigma around that is silly. It's sort of like the stigma around having, is it gonorrhea or herpes, or one of them? I can't remember. God, and now I'm pulling out statistics out of my butt. But I remember hearing that there's some STI that a majority of Americans have, or a majority of particular demographics have anyway. So it's extremely mundane, and yet no one talks about it. No one, or very few people, walk around talking about it. Actually, I went years ago, this was 10 years ago, I was invited to be a panelist at a convention in Seattle for people around the world who have a STI. So it was a convention for people to basically come out of the closet with each other, and it wasn't like some kind of sex meetup. It was like a convention like any other at a hotel in Seattle, and blah blah blah. And people talked about the stigma, the wrong-headed stigma about STIs, and it was interesting and I was there to talk about how to talk with your spouse or your romantic partners about your STI, but before you engage in risky, behavior. And so I worked up some kind of thing on that. But the interesting thing was, even at this convention with closed doors, people showed up with disguises on. They would show up with wigs and sunglasses on because they didn't want to have anyone know that they had an STI, even though I can't remember the stat, but a lot of people have STIs, particular STIs, and it's, herpes, for example. You get a herpes sore on your mouth, and people don't, or I guess most people don't think that's a horrible thing. Anyway, my point is that we have a lot of wrong-headed stigma in our society. And anonymous patron, what I'm guessing what you're suffering from is wrongheaded stigma around labels in the DSM, and thus you have a wrongheaded shame. And that is unfair to you. It's being imposed on you by society. You've internalized those messages and you're beating yourself up. You need to fight back on that. We all need to fight back on that. We all need to stand up and say, no, I'm not going to believe the hype on that. I'm not going to say that labeling or, qualifying for a label in the DSM is some shameful thing. I'm not going to say that going to therapy is a shameful thing. I still experience people today who are shy about the fact that they go to a therapist, and they're talking to me, and I'm like, I'm a therapist, right? Like, there's no shame in you going to therapy. That's my job. It's not like I work at a porn shop or something where I would understand, given the constraints on society that, my point, there should be any stigma around porn, either. But my point is that it's so shameful. There's so many weird shames, and we have to fight back on that. And that's what I'm, saying to you. Okay, so let's go on to another email. What do you say? But before that, let's take a break. All right, we're back from the break. This next email is from someone that I don't have their name, but I'm sorry. They're asking about a couple of questions. Their first question is, I am seeing a trend of court-ordered co-parenting counseling. The co-parent counselor is often required to communicate with the court either in a report or directly with the judge and weigh in on custody decisions. How is this not a dual role? Good question. A question I get a lot, and the situation I see a lot of. So basically, if you don't know what this is, essentially what this is you have a family that is going through a divorce, and the judge will order the divorcing parents, to go to a counselor to talk about how they can both parent their children well through and after the divorce. And that doing that will benefit everyone, and mostly the kids, but even the parents. So that's what they will do. And sometimes what the judge will do is they will say, okay, I want that counselor to report back periodically as they are treating you to help you get along better. And I'm also going to ask that counselor to let me know who they think should have primary custody or something like that. Now, this is one particular version of the story. It'll go various different ways, but I've certainly seen this before. And so this patron is asking, well, isn't this a dual relationship? And if you're not in the field, a dual relationship, a dual role is when, as therapists, we involve ourselves in more than one role, meaning that so in the dual role in this situation is the therapist being contracted to work with the family is a therapist. So they're helping the family with therapeutic services to help them parent better and get along better and help the kids help the whole family adjust to divorce better. And they are also in a different role, which is the role of evaluator and the role of court reporter, which is a wholly different role. And the patron is asking, how is this not a dual role? And the answer to that question is, it absolutely is a role, and it's a conflicting role. It's completely conflicting. There are some dual roles that you can justify, like, for example, it's the same principle applies to supervisees. So, for example, I have supervisees who are therapists who hire me to supervise their work with their clients. And I will also see them at social events. Like I'll see them at a party, or I'll see them at a conference or something, and we'll talk. So that is considered in our field a dual role. I'm providing a supervision service to that person, and I'm also fraternizing with them to a certain degree in my social life. Now, they're not my friend. I don't hang out with them as a friend. They're not, we're not, I don't know, in some other involved relationship. But it is a dual relationship. And as long as we enter that dual relationship with care, and I make sure that I'm not harming the supervisee, and I ask the supervisee how they feel about it, then the risks involved in that dual relationship can be mitigated. However, there is almost no way to mitigate the conflicting tasks and roles involved in providing a therapeutic service and providing a custody battle evaluative service. There's no way. You cannot provide therapeutic services and also provide evaluative services to the same family. It just cannot be done. It's explicitly stated in, I believe, all the ethical codes. I know it's in the APA code. I'm guessing it's in the ACA code. It's definitely in the Marriage and Family Therapy Code. There's a little bit of wiggle room if you really know what you're doing. There are some people who can do this and manage it well, but unless you're supremely confident in your ability to not get sued and to navigate that very risky realm, you really need to avoid this. And it's something that I see people go into all the time. And I have to say, I did too when I first started out, because I didn't have good supervision or guidance around this. There's a lot of times where the courts or the lawyers or the clients will ask their family therapist to provide an opinion in court. They'll say, can you please come to court and testify for one thing or another? And because I just didn't know, I would just go. And it never felt right to me. And there was a reason for that. It's because, one, I was in a dual role that was extremely problematic. Just for example, hypothetically speaking, if you were treating a family for co-parenting and they also know that you are evaluating them to determine who is the best parent, and you're going to report to the judge who is the best parent and who is the worst parent, when they show up for therapy sessions, they're going to try to act like they are awesome. And the kids will also know this. So when the kids and the parents show up for the counseling and the therapy, they're all going to be affected by that. And say the kids have decided that dad is a little too strict, and for whatever reason they just want to live with mom because mom is really passive and they get to do whatever they want at her house. And so what they'll do, because they know that you're there to evaluate the good and the bad parent, they'll show up and they'll just lie about the dad. They'll, oh, the dad's really mean and we don't love him and he doesn't love us. And, and so as a therapist, you're trying to help this family actually become, a more cohesive, more functioning family. And people are coming to the session lying to you because they're worried you're going to make a decision about their lives in this very critical way that is going to make their life better or worse. And therefore, the therapy is going to suffer greatly because they're not showing up honestly. And that's just one example of the many conflicts that can occur in this dual role. So yeah, absolutely, patron, you're right. It is a dual role, and you shouldn't be doing this. And no one should be, honestly, in my opinion. There's a very strict line in psychology. There's a whole profession of people who provide evaluations for this sort of thing. There's a whole profession of people who are trained to figure out competence of parenting. They will observe the parent. There's a whole system. There's personality tests. There's parenting suitability tests. And it's all scientific. It's all, standard. It's basically forensic psychology, and it's a field. But just because you're a therapist and you know how to help people have more functioning families does not mean by default you also know all the things involved in this other profession. And just because you might think you have opinions about, or just because you might think your opinions about a family are valid, doesn't mean that they're valid in a legal sense. So, and that's what a lot of therapists fail to understand, is that, just because you know how to provide a therapeutic service or a counseling service doesn't mean you understand forensic psychology. It just doesn't. And so, you just have to check your narcissism on that. But more likely, it's not narcissism. It's just that you've never been taught that you shouldn't be doing that sort of thing. I can't tell you how many of the legal cases that I've been a consultant on or that I've read about that involve this very thing, where counselors and therapists will dip into essentially forensic psychology and provide parenting evaluations when they've never been trained for such a thing. And they get sued successfully because it's a dual role, one, which you can get sued over successfully, and they're not competent in providing that opinion. And their opinion was found to be biased. So that is a surefire, and you have a parent who is a victim of your incompetence, and so they will sue you. I mean, you get in the way of a parent and their kids, and they're going to fight you. So you better know what you're doing. So, anytime the court asks you to do stuff like that, if you don't know what you're doing, immediately go to a supervisor or a consultant and figure out how you should respond. Because even the way you respond, even if you say, no, I'm not going to do it, there's a way you need to respond to the courts that keeps you out of trouble. So one is yes, it's a dual role. The second thing is again, scope of competence. Are you competent in providing that service? And the questions you want to ask yourself, if anyone ever asks you, please provide, an opinion on custody, or, come to court and tell us what the problems are in this family in relation to custody, the question you have to ask yourself is how many classes or supervision or internship experience have you taken on how to evaluate custody? Just ask yourself that. If anyone ever asks you to weigh in officially on custody and provide any kind of comment on custody, just ask yourself, how many classes about custody and parenting fitness have you taken in a legal sense, in a forensic sense? How many tests have you ran? How many people have you consulted with about this matter? Or are you just speaking off the top of your head? And I can tell you from experience, because I didn't have good guidance at the beginning of my career, that's what I did. People would ask me my opinion. I'd be like, well, I think the kids would be better off with the dad. But that's just my clinical opinion, which is fine. But when you submit that to a court, you better know what you're doing. And there's a whole profession. Other questions, how many classes and supervision and internship experience have you had on how to report to the court? How much supervision have you had regarding writing a report to the court? How much supervision have you had regarding how to not get sued during a custody battle? How many classes have you taken on how to not get sued during a custody battle? If you haven't taken any classes or received any supervision or sufficient experience, supervised experience doing those things, then don't do it. Because the answer is you don't know what you're doing. Just because you think you know what you're doing, or just because someone thinks you should know that task, doesn't mean you actually know how to do that. And again, I've seen so many people get sued this way. The other thing to keep in mind is just because the court asks you to do something does not mean that it's legal or not risky. Just because your clients ask you, just because a lawyer asks you, again, just because a judge asks, just because your supervisor asks you, actually, does not mean that you are doing something that is legal and not risky. Courts have asked me to do things over the years that have been extremely risky to my career. And in the beginning, I was really confused by that. But over time, I figured out that one, judges are human beings who have limited knowledge. These are not geniuses. They're just regular workers. They're just regular government workers. And boy, do they not know some things. And boy, do they not understand the field of family therapy. I didn't meet a single judge, and I met dozens, who really fully grasped what therapy was for. I mean, maybe they did, but they didn't exhibit that they got it. And there were some judges that supremely did not understand what family therapy was and were bullies and abusive as judges. And so now some judges were nice, but the point is that just because a judge asks you to do something doesn't mean that you're supposed to do it. It's not like you can say, well, the judge told me to. That doesn't save you from needing to follow your own professional ethical codes. And again, just because a client asks you, or just because the client says, well, a judge asked me to ask you, don't be intimidated by that. Say, well, they've asked me. Let me look into making sure that that's what I'm supposed to be doing. Let me make sure that I'm competent. Let me make sure that there's no risk to my career. You really want to push back on that. And my general rule for novice therapists and my supervisees is that you will not do, when I first take people as supervisees, what I tell them is, unless you can demonstrate to me that you really know what you're doing, you are forbidden from involving yourself in any court proceeding. Just so you know, as your supervisor, if anyone asks you to do anything in court, you cannot do that unless you can prove to me prior to doing the action that you know what you're doing and that you and I are not getting in any kind of risk here. Because the fact is, if they go out and do something unethical and get sued, I can get sued too as their supervisor. And so what I tell them is, you're forbidden from doing that. And the universal response from my supervisees about that is, thank you for saying that, because I don't want to do anything in the court, is what they say. The court scares me. And what I say is, well, good. It's good fear, because it's a scary place. And unless you really know what you're doing, that fear and that ignorance will bite in the ass. Having said all that, what you're talking about is co-parenting. And co-parenting counseling is great. I've been doing this for years. I don't call it co-parenting counseling because I've been doing it before that was a term. It's just called family therapy or couples therapy or marital therapy or divorce therapy or something. All these phrases some author comes out and says, oh, co-parenting counseling. It's like, okay, it's also just called family therapy, But anyway, that's just a pet peeve of mine. The point is yes, co-parenting, family therapy, it's a thing, and it's a wonderful thing. And if every divorcing couple did this and those who couldn't afford it had it paid for, the world would be a much better place. I'm here to tell you that. And when I have provided this service, I've sent letters to courts saying that they've attended, but I don't provide an evaluation. Even if the judge explicitly asks me, I need you to testify in your opinion about, custody regarding these two parents. And then they drag me into court and they subpoena me, and there's certain subpoenas you have to attend. And so I'll go and I'll sit on the stand, and they will ask me questions, and they'll say, so what's your opinion about the custody between these two people? Who do you think is more suitable as a parent moving forward? And I'll say, I'm sorry, I don't have an opinion on that because I was providing therapeutic services, and I ethically cannot provide that opinion because that's a dual role. And what I told the family, if they need someone to provide an opinion on that, they need to hire a separate professional that is not providing therapeutic services and therefore won't be biased. And they will be able to evaluate thoroughly and provide a forensic legal opinion on that very question. But I cannot, because I'm a therapist, and that is not my job. It's not my job as a therapist to evaluate whether or not a parent is a good parent. It's my job to provide a therapeutic service, and that's what I did. And often all I need to do is send the judge a email about that, and they don't ask me to come because I'm just going to waste everyone's time. And you have the ability to do that. And there's nothing anyone can do to you if you do that. In fact, if you don't do that, they can do a lot of things to you. On the other side, I have provided forensic evaluations and have provided court, reports or reports that have been used in court. But with those clients, I was not their therapist. I was only their evaluator. Okay, so moving on with your questions here, patron, you said, I just took a workshop so it's this co-parenting workshop thing. During the workshop, it was given by a marriage and family therapist who works as a co-parent counselor. But I thought she was so demeaning to her clients. It seemed like she really hated her clients and called them things like immature and failures as parents. Yeesh. And she showed a cartoon image depicting the parents as fat, big-nosed, screaming babies titled, What High Conflict Parents Look Like. Yikes. Yeah, I've seen this before. I've talked about it before on the podcast. There are some people in our field that when you consult, or you get them away from their clients and they speak freely, they exhibit a very hostile, what I would call actually immature attitude about their clients, a very jaded, judgmental attitude where it seems like, the impression I get about these clinicians is they hate their clients and they're just secretly judging them the entire time. And it's abhorrent. And it's immoral to be that way, in my opinion. It's not just unprofessional, obviously, but it's also an immoral act. People come to you for help. They are suffering. And when you are secretly judging them and making fun of them, it's like kicking someone when they're down, honestly. And it's like kicking someone who's down, who's asking for you to help them get up. It's despicable to me. And these people need to go away for a while. They need to go away and heal from their wounds, their childhood wounds or whatever, and maybe consider coming back. Or they need to go away and heal from their burnout. Maybe they're just burnt out and they need a break. For sure, just go away, take a break, get your compassion back, and come back when that happens. Or honestly, those people just need to stay away. Because I don't like it. The other thing is that I'll say, unfortunately, in our profession, there are pockets within our profession where there's a certain culture of animosity towards clients. And I've talked about this before, but I'll be I've worked at a number of different contexts and agencies and stuff, and you'll go to a case consultation group where it's just a bunch of clinicians sitting in a circle talking about their cases and other kinds of stuff. And there are some groups who will talk very mean about their own clients. They'll be like, oh, I got so-and-so again, that borderline cutter, I got her again. She's driving me crazy. I can't wait for her to drop out of therapy. And, just really hateful, what I consider to be immature, immoral, hostile, just ridiculous attitudinal statements about judgments about their own clients. Look, if you need to vent, for sure. If you're suffering, get it off your chest. But at the end of the day, you have to come back to compassion. You have to balance yourself out and say, well, the reason why they're giving me trouble is because they have problems. And because they were traumatized or because they're scared or something. And, it certainly makes it hard for me as a clinician trying to help them. But I see why it's happening. It's not, I'm not going to take it personal, and the clients aren't evil, and they're really trying. And I'm, so again, it's okay to vent. That's good. It's good to vent. But in the end of that venting period, there needs to be a balance, and there needs to be perspective, and there needs to be compassion. And if you can't do that, then you just need to go away, in my opinion. There's many professions on this planet that it's fine to judge your customers or whatever. If you're a McDonald's cashier, feel free to judge the customers. Oh, that customer, that's a stupid that's fine. It doesn't interfere with your ability to take someone's order. If you're a CEO or if you're a business owner, you own a shop that sells jeans, feel free to talk shit about your customers. It's fine. It doesn't matter, because the people are coming to you for jeans. They're not coming to you for compassion. People are coming to us because they're suffering and they need our compassion and they need us to care. And if you can't do that, then you need to not be close to your patients. You need to actually go somewhere else and do a different job, in my opinion. Again, all of us have our bad days. All of us slip into judgment every once in a while. But this sort of toxic hostility that I see among some of these clinicians that I'm sort of referencing, it's every day and it never ends. And when I try to say something like, well, let's try to take it easy on these, these people are suffering. Let's try to keep it all in mind. They'll be like, well, and then they just go right back to it. And so, that's what I'm talking about, is that sort of, and I've seen it so many times. And it feeds off each other. So, if you get two clinicians who are like this, they'll sort of like, enhance each other's judgment and negativity about the clients. And then other people kind of feel like they need to join in to feel like they're a part of the group, to be accepted by the group. You gotta laugh at that client a little bit. You gotta join in. And I've been there, and I hate it. I just think it's, and I see it towards students too. I'll see professors get together at my university, and it's same attitude. It's like, oh boy, you wouldn't believe the batch I got this time. And every time it hurts me. I'm thinking, again, vent. Sure, you're stressed out. You're confused. You have a few students that you're a little confused by, but to just have a general attitude of just like, us versus them, those idiots, those idiot kids and those idiot, it can't be good for the soul, and it can't be good for the profession, and it can't be good for the students and for the clients. It just can't be. All right. Well, that does it for that episode of Psychology in Seattle. Thanks for joining me. Please take care of yourself, because you deserve it. You really, really, really do.